لحظة 10 ثواني. We can start.
Okay. بسم الله الرحمن الرحيم. السلام عليكم جميعا. Thank you for attending us our 7th scientific Cath Lab Day. This year is going to be like a special day, a special year, because it's going to be a virtual meeting because of the all of us know about the COVID pandemic. So I would like to thank those who attended yesterday our meetings, and special thank also for those who try to log in, but maybe due to internet connections or due to any technical problems. Anyway, I hope those who couldn't join us yesterday could join us today. As a continuation of the yesterday's activity, today we are going to continue with our third session, which is talking about electrophysiology. And thanks for those who are with us today, and special thanks for the speakers also. And before we start introducing the speakers, and we'd like to, on my behalf, my name, and we'd like to thank the organizing committee also. To introduce my name, I'm going to be the moderator for this day. My name is Saleh Al-Harthi. I am a perfectionist at the National Health Center. So I'm going to be the moderator for this day. Let's kill the time, and let's start our sessions with Dr. Mohammed Najib Al-Rawahi. He is a consultant electrophysiologist at Sultan Qaboos University Hospital and National Heart Hospital also. He's going to talk today about non-pharmacological treatment of atrial fibrillation. So, Dr. Mohammed, you have like 20 minutes. I'm going to warn you before 2 minutes. So, microphone with you.
Thank you very much. Assalamu alaikum wa rahmatullah. I hope you can hear me clear and sound. Okay.
Yes, we can hear you, bro.
Perfect. So as an electrophysiologist, it's kind of weird to talk about non-ablation, non-pharmacological therapy of management of probably the most common arrhythmia in the world, which is atrial fibrillation. But the reason why I chose the topic, it's because it is important to address all aspects of management of atrial fibrillation, including the non-pharmacological aspect of therapy. So without further ado, let me start. There's no disclosures for this talk. So this is the outline of my talk. I'll basically just talk about AFib burden in 2020, and then risk factors of AFib that we are trying to manage to prevent, as well as treat AFib or prevent AFib recurrence in the future. And then what are the measures that we can do non-pharmacologically, and obviously without ablation, or in conjunction with ablation as well. So what's the burden of AFib? We know that AFib is the most common arrhythmia in the world. Around anywhere between 60 to 75 million individuals in the world have AFib or flutter, and this as of last year. And it's doubled in the last 30 years or so. So if anything, it's in the increase. And there are a lot of disabilities due to AFib, whether because of symptoms or complication like stroke. And this is basically calculated by something called daily. It's around 8.39 million in 2019 from 3.8 million in 1990. So you can see that not that we have a lot of AFib, we have a lot of disabilities from AFib. This is from the European Heart Association guidelines. And they basically spoke about prevalence of AFib in Europe. And you can clearly see that AFib is more common in men than in women. Though this difference is basically disappears with increasing age. What is more interesting that the more risk factors you have, the more likely you might develop AFib. And what they say is, what they noted is the risk of having AFib above the age of 55 is almost 1 in 3. So it's a huge number. And you can imagine the financial burden of having AFib is tremendous. So this is from Australia. And if you just basically follow the blue bars, these are admissions of AFib in Australia. And you can see, compared to other cardiovascular admission, like heart failure and myocardial infarction, and if you can clearly see that AFib is increasing at an exponential rate. And these numbers are like in 2013, it's probably double the numbers now. So AFib is the most common reason why patients get admitted to the hospital. So what are the risk factors that we're talking about? So if you see, these are from the ESC guidelines. Treatment of atrial fibrillation has 3 pillars. The first pillar is anticoagulation to prevent stroke. Symptoms control, and this can be achieved either by rate control or rhythm control, and ablation is becoming like hot topic in this arena. And the forgotten is cardiovascular risk factor management. And in my talk, I'll try to convince you that managing risk factors, basically you will be able to prevent recurrence and prevent development of AFib in the future. So AFib is a complex disease, and the development of AFib, it's not straightforward. There are many, let me get this out of the way. So there are many changes that happen in AFib. The main thing is remodeling, whether it's electrical remodeling, structural remodeling, something to do with calcium abnormality, as well as autonomic nerve remodeling. These all contribute somehow in development of atrial fibrillation. And we know that all of these risk factors, some of them are modifiable, like hypertension, diabetes, obesity, physical inactivity, as well as obstructive apnea, OSA, all basically promote development of atrial fibrillation. And if we basically target these risk factors, these remodeling changes that happened in the atrial myocardium decreases, and I will show you a few examples during the talk, by which we prevent atrial fibrillation development and recurrence. So the thought was, patient will start with, paroxysmal atrial fibrillation, and then with time will progress through persistent, and then will end up having permanent AFib. But this is this data from a German registry. What they discovered is the more number of cardiac risk factors the patient has, the likelihood they will present with more persistent or permanent form of atrial fibrillation. So, and it's quite interesting that treatment of these risk factors, you can basically reverse the process. So if a patient is, say, for example, has persistent fibrillation, by just treating the risk factors, maybe you can reverse the AFib pattern from persistent to paroxysmal to sometimes cure. So I think the epidemic that goes along with atrial fibrillation is obesity. Obesity is almost everywhere. And it's very clearly known that for every 5 units BMI increase, there's almost 30% risk of AFib development, 10% risk of AFib post-op. And it also affects treatment, like our ablation in patients who are obese, with 13% risk of AFib recurrence post-ablation if the patients are obese. And this basically is reversible, as will be shown. So these are, this is a study done in Australia where they took sheep and they were fed until they were obese, and they basically examined. So this is myocardial muscle, and basically you can see the red stain of the obese sheep is very full of these red stain, which is basically indicating fibrosis. This is basically an electro-anatomical mapping, and you can clearly see these isochronal crowding here in obese sheep. Just tells you that there is slow conduction from one point of the muscle to the other points of the muscle. So basically just promoting re-entry and AFib. And it's more interesting is AFib inducibility as well as spontaneous AFib development were observed in obese sheep that was not seen at baseline. So we know that there is direct relationship between obesity, increased fat, whether locally around the heart or in the muscle of the right and left atrium, and AFib development. This is basically kind of a nice summary, basically showing you control on the top row, as well as diseased electroanatomical mapping. Red is bad. Purple or blue or even green is kind of normal. So what you can see in this is age, hypertension, heart failure, sleep apnea, lone AFib, as well as obesity. So you can see that with all these risk factors, many of them are modifiable, there is more diseased myocardium. So even in patients with lone AFib with no risk factors whatsoever, they have these red slow conduction. Okay, so the hypothesis by treating these reversible causes like hypertension, heart failure, sleep apnea, and obesity, we can basically reverse the process from this being red into a normal myocardium. And that's what has been shown repeatedly. So what are the risk factors that we should target? The modifiable one are hypertension, physical inactivity, obstructive apnea, hyperlipidemia, obesity, and hyperglycemia. This is a study from Australian group. So basically what they did, they had a long waiting time, patients waiting for AFib ablation. So what they did, they randomized 150 patients who had a BMI more than 27 to usual care versus intensive and aggressive risk factor modification. And these were the points that they basically stressed on. So weight management and exercise. So the target was to increase at least 10% of weight, as well as to exercise daily. Treat dyslipidemia, treat obstructive apnea aggressively. And these patients were referred to a sleep physician or sleep specialist to treat these patients, and who required a CPAP or prescribed one. Very aggressive hypertension management with a blood pressure of less than 130/80. And they even did a stress test. And even if the blood pressure was above 200/100 on stress test, they were treated, preferably with an ACE inhibitor or an ERB. And there were few studies that showed treatment with ACE and ERB might either prevent AFib or even decrease recurrence in the future. And it was in the guidelines, AFib guidelines 2017. Treatment of diabetes, smoking, and alcohol abstinence. So this was the frame of management in the intensive group. And they had measurable changes. So body mass index is a good measure of success. And you can clearly see over the study period that decreased more than 5 to 6 points. So patients who underwent intensive control had very good response in terms of measurable body mass index and weight circumference decrease. So what are the results? So patients who were in the intervention, the intensive aggressive risk factor modification or treatment group, had significant improvement in symptoms, as well as on a 7-day Holter monitoring had less recurrence. And those who had recurrence, they had for shorter period of time. So what they did, they basically had an observational study, the Legacy trial. Observation study of patients who were obese. They had almost had 825 patients, and they were basically categorized based on their weight loss. More than 10% weight loss, around 3 to 9% of weight loss, or less than 3%, or changing weight, basically weight gain, weight loss, which is not consistent. What's interesting is without ablation or antiarrhythmic therapy, almost half, 46% of patients had no atrial fibrillation in 5 years without ablation and without antiarrhythmic therapies. The group who had ablation or antiarrhythmics had very graded response. So if they had weight loss more than 10%, they had 86% AFib freedom in 5 years. And if the weight loss was less, the freedom was less. So these are remarkable numbers. So if the more than 10% weight loss was associated with AFib-free survival with a hazard ratio of almost 6. They took it even further. So not just the weight loss, even the endurance or exercise capacity. So if you basically lose weight as well as gain 2 METs during cardiorespiratory fitness, you basically have increased AFib freedom over 5 years, 2 levels up to like 76 to 80%. This is an interesting study where basically we kind of know that AFib usually progresses from paroxysmal AFib to persistent to permanent. And what they've shown that patients who had more than 10% weight loss had very minimal progression. And what is even more interesting, those who lost weight in the orange group here, more than 10%, they reversed. So basically from permanent to persistent to paroxysmal, and many of them, almost 90% of them, had either paroxysmal or no AFib. So it's kind of interesting observation here. And this is basically what happens electroanatomically. So control is on the top, and the bottom is basically after 12 months. So these patients with no risk factor modification, you can see there is increased red in the map, just telling you that the disease progressed. But those who had intensive risk factor management, all these red episodes after a month disappeared. So it just tells you that whatever these lifestyle changes is measurable electroanatomically by reversing the fibrosis that happens in the heart and decrease in AFib recurrence in the future. So we know that by managing risk factors, we're inhibiting a lot of pathways and basically decrease the incidence of progression of AFib and in fact reversing AFib and treating it. So how they did it, and these studies are from Australia. They had AFib management team, i.e. electrophysiologists, and they basically managed symptoms as well as oral anticoagulation. And they motivated patients to undertake risk factor management. But they had another team led by a doctor, and they basically focused solely on reducing weight, improving exercise, managing hypertension aggressively, decreasing blood sugar, as well as dyslipidemia. And it worked. There's another group who basically had a nurse-led team instead of a doctor. So a nurse-led team, and they had kind of an electronic record where they tick. So weight decrease, hypertension, diabetes, and it was basically kind of standardized. So half of the cohort had this nurse-led care group, and half of them were usual care. And what's interesting that almost 35% relative risk reduction in those who had nurse-led care, and this decrease in AFib recurrence as well as mortality. So the paradigm now is shifting. AFib management is not solely the job of an electrophysiologist. In fact, an electrophysiologist has a very small part in the management of atrial fibrillation. So it's basically a collaboration between primary care physician, nutritionist, sleep therapist or sleep physician, pharmacist, psychologist. So basically it's an integration of these, and probably the primary care physician or the general cardiologist is the focal point, and the AFib specialist is one in a big picture. So what are the modifiable risks that we aim is to treat sleep apnea, is to increase or basically increase exercise. But exercise is tricky. So doing exercise 3 to 5 times for 30 minutes kind of is acceptable, but in extreme marathon, high intensity endurance sports, it has a paradoxical effect and may increase incidence of AFib. Very strict blood pressure control, preferably less than 120 over 80. Treatment of diabetes, weight loss of more than 10%. And what's interesting, or it's basically happening, the ESC guidelines in 2017 had class 2B indication or 2A indication for risk factor management. And now in 2020, it's class 1 indication to treat patients with AFib, to treat risk factors in patients with AFib. And it's more or less the same in the 2020 Canadian guidelines. So this is, in a nutshell, the non-pharmacological treatment of atrial fibrillation. Unfortunately, we don't have it here. We don't do it here structurally in Oman, but hopefully in the coming future. I know some countries nearby, they instituted AFib clinics. Hopefully soon we'll have one. Thank you very much.
Thank you, Dr. Mohammed, for the valuable and informative lectures, and you really make it on a time. Thank you very much. So let us see if there is any questions. I cannot see any question here posted. Just have an inquiry, Dr. Mohammed, if you can hear me.
Sure.
Any percentage recorded the causes of sudden death, especially with athlete people, caused by AF, or there's no documentation about it?
If I got your question correctly, what's the percentage of sudden cardiac death in patients?
Yep. Yeah, especially the athlete people.
So this is a totally different topic. But we know that all cardiovascular abnormalities, including channelopathies, cardiomyopathies, usually happen with exercise, except 2, Brugada syndrome and long QT. So it's not uncommon to have patients die, or we see kind of in our clinical practice, patients who are athletes develop sudden cardiac death, and it's probably more shocking in patients who are young with no background history or medical problems. What's the percentage locally? It's I don't think we have data. There are data in Italy and US. In Italy, the most common cause of sudden cardiac death in the young or athletes is because of the RBC. In the States, it's because of hypertrophic cardiomyopathy, especially in the Black community. In Oman, study undergoing, where they study what are the reasons for sudden cardiac death. Exercise is a bit tricky because, as I said, very high endurance exercise, these patients will develop or they have higher chance of developing AFib. But exercise in moderation is always advisable, and as clearly seen. The only condition where you can think of where athletes dying suddenly of two conditions, well, if they had accessory pathway, they develop AFib and they die because of that, or if they had a combination of something called short QT syndrome, where they can have AFib and die from it. So this is a different topic, sudden cardiac death.
Oh, that's different. Yeah, okay. I know that because the sudden death has a lot of contributing factors, which might lead to there's no specific causes. I just was wondering if AF has something to do with that. Was clear. Your explanation was clear. Thank you very much, Dr. Mohammed. I don't know the control room, the control panel, whether they have can see any questions, because I cannot see any questions from the audience.
I think my lecture was very clear.
Yep, you are right.
Well done, Dr. Mohammed Najib. I cannot see any question.
Yeah, okay.
But I like the question of Saleh. We have to remember that AFib is a stress on the heart. And whenever you have higher ventricular rate, so the stress is more and more. So it unmasks any hidden problem that may cause to arrest, like people with short QT, long QT. The variability of the QT during AFib also may influence this. So if you have on top of the atrial fibrillation PVCs, it may be easier, trigger some problems. So it's a nice question, but maybe it's better to go for.
Yeah, exactly. Okay, our next lecture is going to be with Dr. Ghalia Al-Muhanni. Dr. Ghalia is a senior consultant electrophysiologist at National Health Center. I think she introduces herself before we introduce her. So she's going to talk about how to localize and win a battle with the PVC. So Dr. Ghalia, the microphone with you, and let's go.
Okay. So PVC is one of the frequent arrhythmias that we face in our institute, in our place. So what we will talk about how can we localize, and first of all, you need to know all your anatomical possibilities of PVC origin. So this will help you more and more to localize the PVC. So you, as we know, we have the outflow, which is coming either on the right side or left side, related to the pulmonary artery or aortic valve, and around this area, a lot of PVCs may originate. And the most common PVCs come from these places, especially if the patient is usually healthy and have only a focal PVC. And then we have below them the tricuspid valve and the mitral valve, and around this area a lot of other structures that we have to consider, like the papillary muscles. And then we have the Purkinje network and the LV apex and other, like the moderator band, and we will see. Okay, so about the ECG is one of the very good tool to at least orient us about what we are dealing with in the PVC. So remember, if you have a 12-lead ECG, V1 and V2 already give you very good information. If you are dealing with a PVC, where you observe always, as electrophysiologists, we observe V1. Of course, we see the axis, if it's superior or inferior. What I mean by superior and inferior, if it's inferior axis, so something coming from the upper part of the heart, and usually is positive in the inferior lead, so something looking from up to down. Okay, and then we start to observe V1. It's the outflow usually are an LBP morphology, and then we start to observe the R and how does this R grows. Remember that the V1 is usually reflecting the right side, and V2 is more to the left side, and what's coming far away from V1 is more coming from the right side. And once we start to have R wave, we may start to have something coming from the left side. And like this, we start to finalize our origin. Other thing, remember the outflow is small structures, are two tubes, one in front of the other. So the variation in the QRS is really small. It's not like when you go down more and more to a wider area of LV and RV and you start to have a definite other shapes. So it's more difficult to localize BBC from the outflow as segment, I mean. Another theory that was suggested is to imagine a midline between the right-sided and the left-sided, okay? And then to divide this left side, which is left to the midline, which is this right to the midline, and the right-sided. And then all the structures that are coming posterior to this line are related to the RBUT, and this is which is coming here anterior to the line are related more to the LV. And then to imagine here we have the pulmonary artery, the aortic valve, and what's coming more posterior is related to the aortic root, and what's coming anteriorly is related more to pulmonary artery and the related coronaries, which is important to remember these relations. So more and more we are becoming more specific in other signs that we have to see and observe. Of course, if we are considering an RVOT PVC, usually we see the V1, it's LBB morphology. You don't have an early transition of the R. You don't have even an initial R, except if you are septal, because now you are coming more and more to the left side. Still you are in the RVOT. And then how can we differentiate between septal and lateral wall? Of course, here you can observe also how is the QRS, how is it narrower or wider. If you have notching in the inferior leads, it's more indicative of lateral and free wall. If you have the R wave and deep S is coming until V5 and the transition is late, this may take you more to the free wall. And the free wall is of course, you can consider free wall from endocardial to epicardial region. And here, when you come to the septal, so you may have a very deep focus of the septal PVC. What about the tricusp? Again, we will go down to a structure below the RVOT, which is the tricusp, and it's important, especially in arrhythmogenic dysplasia in our area, because it's related to rheumatic heart disease and pathology is related, and we had several cases of VT coming from a peritricusp area, and not easy. Again, you start to see the positivity in lead 1, because when you go more far away from lead 1, you start to have a positive lead 1. And then you can see also here V1 and the transition of this PVC, the notching, all these are more indicative of origin coming from the tricusp. Observe the AVL, how is it? The AVR, it's more negative than the AVL, definitely. And because you are coming from far away from the AVR, so here is more, definitely more negative. So these are also signs to observe more and more to specify. And here you imagine is something more less benign than a PVC coming from the outflow. So you may think about other things like the patient may had myocarditis. We had a patient with thalassemia with VT related to tricusp, or maybe arrhythmogenic dysplasia. Again, coming back to the structures that are below the outflow. Again, we have to consider also the aortic valve, the mitral valve, which is coming even more posterior and lateral to the aortic valve. So if we already assumed from our ECG that we are dealing with an outflow PVC, Of course, we have again this positive leads in inferior, so you have inferior axis coming from up, looking downward. And then you start to have V1, which is already positive. Maybe here you don't have, in this septal you have initial R, but here when you go more anterior, more lateral to the aortic valve going toward the mitral valve, and I show you later other ECGs, you have to consider this PVC coming from this area. And then there are structures related to the mitral valve itself that we have again to refine. So here what you see, already you see an RBB, which lead you to more lateral and anterior lateral to the mitral valve. And still it's from the outwards coming from the upper part of the heart, from the base of the heart. So you still see the positivity. Here you have the mitro-aortic continuity, which is a thick place to ablate. So also this is another origin of PVC. Okay. There is another sign that we learn more and more to recognize it. If you have already an initial R, and then I usually call it the W sign. You have a deflection and then upright and then deflection. This may indicate you have already lead 1 is negative, so something coming far from this part of the heart this way. So you are having something from the LVOT between the right and left commissure of the coronary cusp, and here this is not an easy area, especially if you remember that you have here already the left main with the division of the LAD and circumflex. So it's an area of consideration if you are going to ablate. Here is the ICE, as Dr. Muhammad Najib likes to show you the position and refine what is the position of this catheter. Of course, by the eyes, you can see the also ostium of the coronaries, and you can have more and more clear vision of the PVC. What we are looking for, of course, we are looking for the early signal. So it's where is the focus that originates this PVC, and sometimes you see already a delayed diastolic potential that may indicate that you are in a correct position of consideration for ablation. So we have, as we said, these structures. We have the aortic valve on the left side. We have the mitral valve. So we have to imagine we are coming from lateral to the mid area, including the aortic mitral continuity, and then to the aortic valve itself, from the commissures between left and right, from the non-coronary cusp, from all these other, you can already indicate them by ECG. How? Again, you can see lead 1. If it's when you go more basal and more lateral, you may have positive, and then you start to have here a more negative lead 1. You have here V1 that is growing, becoming more bizarre, more wider. So this is indicating more lateral origin. And then you come to a narrower QRS in front of the aortic valve, and sometimes near the hist that you may trigger from the aortic valve, or you may ablate it. Tamam? Another thing, we have to remember that the ECG position is very essential in determining the origin. So when we put the position of the peripheral leads as the exercise, you assume that you have already a different axis of the PVC that you see from the ECG at the department. This happens sometimes when we receive a patient in the cath lab and we have the PVCs coming different from what we saw from the department. So this also is highly dependent on the position of your peripheral leads. Another origin of PVCs that we have to remember, which is related to the cardiac veins, like the great cardiac vein, like the anterior intraventricular vein in this area, which is the anterior sulcus, where here also is a coronary artery going parallel. And all these are places that may originate from around the vein, not from the vein itself, but structures around the vein. Sometimes we have from the posterior septum LV that we may be able to ablate from inside the CS, and has its particular shape at ECG. Another thing that we can observe from the PVC, of course, the LV, it's not a 2D dimensions, 3D coming from inside to outside and sometimes from the opposite. So other signs that we consider when we are targeting a PVC to know, is it an epicardial or endocardial structure? As we know what we do, we just measure the whole QRS duration. More wider is more in favor of an epicardial, and then from the beginning of this PVC to the nadir QRS, and if it's more than 0.55, usually it indicates an epicardial or deep origin. So the case will be more tough to resolve. Okay. Another place is the cardiac crux, which is parallel to the middle cardiac vein. And here, usually the PVC is more bizarre. You have a delay until you create, until the QRS is created. So this is more in favor of epicardial related to the middle cardiac vein. All these are possible origin of PVC. Again, you have from the anterior intraventricular sulcus. So what you have an R wave that suddenly disappear in a V2 and then grow again in V3, which is already present in V1. It's already negative in lead 1 because you have a PVC coming far away from lead 1. So all these are signs that may already show you the challenge that you will face in this case, and then you have to consider the coronaries running near to this origin if you are going to ablate. All these are consideration to plan your procedure. Again, we have the LV summit, which is usually the nightmare of everybody, because you know that the PVC is coming deep, maybe even epicardial, but you know that to get it from endocardial, you have a certain thickness to reach this PVC focus. So usually it's not easy to go get rid of them, and the success is not it's almost 60% in these cases, even if you consider the epicardial origin. And then you have to remember that you have here the coronaries and you have fat around this area that may prevent reaching a good ablation point. Maybe later we will show, maybe next month we will see our results in these cases. And then you have to remember, if you have a PVC that's coming maybe lateral to this great cardiac vein or anterior intraventricular vein, so you may be successful to ablate if you consider epicardial origin, but more septal and more below, you are becoming more at risk because you have here the coronary arteries and the left main. Other possible origin of PVCs, we have the posterior papillary muscle, you have the anterior papillary muscle. Posterior papillary muscle is more septal, and this is more to the lateral wall, and this have definite morphology that we have to also consider. Once we start to have here we see again V1. V1 is right bundle branch block. You have already a notching which is more in favor of something coming from the papillary muscle. You have it already here biphasic, and then it's still positive. So this is more from the anterior papillary muscle because you are coming from here anteriorly. But see if you start to be negative in the inferior leads, how this is taking you more to the septal area, posterior septal area. See how the QRS is also narrower because you are becoming near to the septal area. And these usually PVCs are very challenging. Moderator band has a different type, and it's not easy. Maybe the presence of ice will help to localize and ablate. but it's good to know the morphology that you are targeting and the anatomical position. So I will escape this. Another PBC that is originating, this is becoming also even challenging moderator band, because you will stand on internal structure that you don't know where you are, either on the papillary muscle or tendons. And so again, here an ICE will help you to localize your PBC. Of course, the 3D mapping will help us if we know what we are doing and where we are going. If we are targeting the moderator band, you have, as you see already, a negative in inferior or biphasic in inferior. You have biphasic activation here in lead 2 different than lead 3. So this is more of a diagonal structure inside the heart. You have the LBB morphology that takes you again to the right ventricle origin. So in this case, you may assume that is coming from a common structure intracardiac, which is the moderator band. And then we have, of course, the idiopathic VF that may be related to a single PBC, and it's not bad to know what's the trigger if you have to resolve the VF that is not resolved by medical therapy, or the patient taking frequent shocks. Okay. These are the messages about localization. I will show you different scenarios. But what we are going to see, we are looking for the PVC, where is originating. So as early as much as we can to see pre-QRS, as much as we are going to the origin of this PVC. And of course, then intelligent people like who we have, Nasser and Saleh, they usually are very precise in taking you to the good origin and suggesting where to go. And then you have the unipolar. It's like one eye electrode that it sees when the PVC is going away, the most place that the PVC is going away. So there is no any more backward to see to have an electrical activity. So this is usually the tools. But of course, if we know where we are going, we are reducing already the time, we are increasing the success, is unlike when we go and just look for PVC. I will show you something like this for challenging. This case, this patient had almost 40% PVCs and had already a very low ejection fraction, was 15. And this is, for example, the PVC. As you see, it's okay, it's biphasic in V2 here. And then you have a PVC R wave is already present in V1. You have already an white QRS. And you have this MDI. So you see the slope of the PVC is coming more to an epicardial origin. In fact, this was a very challenging case that we did. We almost ended up by doing 3 maps or 4 maps from inside the heart to outside the heart, just to go and see how we are here lateral to the coronary. So we are less risky to injure the coronaries. In fact, we did coronary angiography to avoid any lesion. And we did ablation in this area, but at the end, this PVC was just going and coming back until we did almost like a kissing ablation from inside and outside to get rid of this PVC. So sometimes it became a major intervention just to get rid. And this patient was young, he's 40 something, and he benefit from doing all these efforts. See here, this is the CS structure, which is epicardially lying on top of this near to the coronaries, and it may indicate also an early activation that is in favor of epicardial origin.
Dr. Ghali, sorry for interrupt you. You have 3 minutes. Can you make it?
I will stop whenever. I'm almost done, but I
okay. Oh, thank you. Thank you.
This is what we see in the patient after getting rid of PVC, which is a very huge stress on the heart by a beating between normal and abnormal beats. Another thing that we need to observe, this is, for example, a case of expected Brugada. He was a Brugada and he had an ICD. And in this case, is the usually that we do is going epicardial and putting down the substrate, which is epicardial related to Brugada. But see what we did here in this case. We found the trigger that was initiating his VF. So we started to target what is the timing of this PVC, and then we, with flecainide IV 50 mg, we could stimulate the outcome of this PVC. So we went to target this PVC. This is another intelligent approach. It's not just modifying the substrate. And we went opposite to the same area that we modified, and we ablated the PVC. Also, the patient until now did 2 years without any recurrence of VF. I will not talk in this now about the Purkinje and the PVC that are related to the Purkinje network inside the heart that may by themselves trigger a VF. So once you identify the PVC that is doing this VF by putting continuous monitoring, maybe documenting this PVC that may trigger VF, it will make you a clear plan what you are going to treat in the cath lab. Like this one of our cases, that he had a PVC that always initiated the VF and he had recurrent VF. So in this case, we went to the moderator band and ablated PVC. I think I will stop here, and in another session, maybe we'll complete other challenging cases. Hello?
Thank you very much, Dr. Ghalia, for
I will stop here, Dr.
Okay, thank you. Thank you very much for the presentation. It's really high-calorie presentation, I would say. It has a lot of information. I don't know the control panel can see any questions, because I cannot see anyone raise any question.
Yes, I received one question
okay.
privately. So, Dr. Ghalia, would you consider CAG for all suspected LV submit PVCs to be a practical habit?
No, it's not. For me, no. As much as we define the origin of coronaries and we are not going epicardial, we don't need really to do a coronary angio, especially if we are ablating below the aortic valve. We have a certain thickness that is protecting any damage that may happen to the coronaries. The other thing is, of course, we usually, what we do, we tag the coronaries origin and how far are they from the site of ablation. So this is also a good approach. So no, it's not recommended. It's not needed in all cases of LV summit.
Any question?
There was a person who raised his hand, but I think he left or something.
Yeah, I saw him. I don't know how. Any question? No. Dr. Ghalia?
Yeah.
I have a query question here. If once you confirm the patient have a PVC, how long it takes to diagnose the original of the PVC? Like it takes long, or is it challenging to specify the origin?
You know what, we like to challenge ourselves, where is the original PVC, and correlate with the procedure itself. But you know, planning where to go and what to do may ease for you the whole procedure, because if you know that's originating from the LVOT, that you still map the RVOT to avoid anything that is missing, especially with the ECG position, rotation of the heart, whatever, you still map the right ventricle, and then you know that your target, you will shift immediately to the left side, and you are not losing time in ablation and putting a lot of effort. So this is, of course, if you have a PVC that you may think it's coming from the epicardial surface, so in this case also you will not spend a lot of time just doing ablation, you know, that's coming so deep until it's coming from the epicardium. So these, it's good exactly to know and to plan your, if you're going to the posterior papillary muscle is different than going from the LV apex or septum. So it's good for you to plan the procedure in advance and to know what you are looking for.
All right. Thank you very much. I think we are going to next speaker, Mr. Saleh, I think. Is it right, Mr. Ahmed?
Mainly now Dr. Ismail, if he's on board. Dr. Ismail?
Yeah, because if he's on board, then we'll introduce him.
He was here. I think he left by mistake or something. Doctor, we'll go with Saleh Shidani.
Okay. Our next lecture or presentation is going to be by Mr. Saleh Al-Shidani. Mr. Saleh Al-Shidani worked as a cardiac cath technologist, and he got his specialized in cardiac electrophysiology, and now he works as a clinical support and specialized for covering the cases which need the 3D mapping support. Mr. Saleh Al-Shidani is going to give us a lecture about implementation of 3D in EB. Mr. Saleh, are you ready?
Yeah, inshallah.
Okay, go ahead. Thank you very much for coming.
You're welcome. Okay, let me just share my screen first.
All right.
So can you see my screen right now?
Yep. Yes, I can see, yes.
Okay. All right, so I'm going to talk about the implementation of the 3D mapping in AP. So the in fact, the mapping started since a long time, as you know, in the early 90s probably, and it wasn't as we can see it nowadays. It was non-invasive and it was more electrical mapping, and that was done by the William Enthoven, who manufactured or invented the ECG machine. Okay, so what mapping means in general? Mapping relates to the assignment and display of encoded information according to its location, spatial coordinates. And in the cardiac field, cardiac mapping needs spatial coordinates of the recording sites and the electrophysiological information of that particular site. In the field, we are having many mapping systems, and the most famous probably CARTO system by Johnson & Johnson, Insight by St. Jude Abbott, and others like Arrhythmia by Boston Scientific and Codex by Philips. And each machine probably it does have different technology and might share the same technologies as well. So particularly here, I'm going to talk about one technology or one system, the CARTO system, because if I'm going to talk about all, it needs more time. So the 3D mapping system, starting with the electroanatomic mapping, and that makes the 3D system, it allows the operator to record intracardiac electrical activation in relation to the anatomic location of the interested chamber. Either can be during the arrhythmia, or we can induce the arrhythmia by the EP recording system. And such a technology makes life simple and enhances procedural success, and particularly in cases where complex arrhythmias and unusual cardiac anatomy are encountered. So this can be done by accurately determining the location of the arrhythmia origin, define cardiac chamber geometry in 3 dimensions, delineate areas of anatomic interest, and allow catheter manipulation and positioning without using the fluoro. So you can see the catheter while manipulating the catheter. Okay. So why to use the electroanatomic mapping systems? So that, as we said, that it's going to be when complex arrhythmias or cardiac anatomy are anticipated, and also we can use the mapping systems during when available information suggests an arrhythmia mechanism located near important structures, and we don't want to damage the that important structure which is not part of the arrhythmia. Could be so, like for example, manifest bypass tract, which is located closer to the AV node, whereas bundle of His also is closer by. So ablation there might cause damage of the AV node or the bundle of His. So the electroanatomic mapping may allow for marking of such structures so that we can avoid them. Also, we can use the electroanatomic mapping system when complex anatomy and areas of scar, contribute the macro reentry arrhythmia. So the mapping is going to allow the operator demarcating such areas so they can, go directly and isolate that area of scar. In non-sustained tachycardias also, we can use the 3D mapping or rapid rhythm disturbances resulting in hemodynamic comprise linked to certain electroanatomic systems as suspected sites of tachycardia origin may be more accurately recorded. So we can target for ablation than using the fluoroscopy alone. And also the mapping, it's reliable and allows the catheter positioning, so we can go each time if we miss the site of ablation, we can go directly because we already have the 3D mapping system geometry with the electrical activity recorded according to the site. So we can go directly if the catheter move out of the area of interest, so we can go back to the area without struggling going back by looking at a dark room, if you can say that. So what do we need to do to start our mapping system? We need to do some setups like localizing our reference. So location reference should be positioned first, and it's a magnet placed underneath the patient on the table, and it must be aligned anywhere inside a defined circumference at the start of the procedure. Before you start your procedure, you have to place the magnet location reference, we call it. And also we got to attach patches to the patient back, roughly overlying the cardiac chamber of interest, and that would allows us for accurate tracking of mapping catheter positioning, consistency of anatomic landmark and ablation lesion locations, and precise reconstruction of the chamber geometry. So as we said that, first we need to place the magnet underneath the patient on the table, and then place the patches, like in this case, in the Carto system, where we are having 6 patches, 3 in the back and 3 in the front. And then you have to place the other involved patches as well, like the defibrillation and the ECG, and also the grounding pads. So what this system is going to do after positioning the 3 back patches, the system is going to read and make a computing the location of the tip of the catheter, which has a reference sensor on the tip of the catheter in reference or in relation to the patches, so that is going to be displayed in the system as distance. And I'm not going to talk about many the technology, because that needs engineered audience and engineer speaker. I'm talking from the clinical aspect. So the second thing, after localizing the patches and the reference, the location reference, then we need to set up our mapping reference. It depends on where we are gonna map. So like we're gonna use the CS, for example, for the atrial arrhythmias, and like, for example, surface ECG QRS complex for, ventricular arrhythmias. Okay. And then we need to also set up our windows of interest. In this window, like in this case here, we are going to focus in this area. This is our interest window. So I'm going to look from this window to the arrhythmia of concern. And it requires accurate determination of the underlying tachycardia mechanism, so we can know what we are going to look at. So you will see during mapping, some colors are displayed, and it depends on the manufacturer. Like in Carto system, it's like from red to purple, and that's according to where is the earliest spot. In Carto system, it's the red is the earliest spot. So what do the colors mean during activation sequence? So it presents the region of, where is the earliest activation from the latest activation, as I said. Like in this case, the earliest point is up underneath the pulmonic valve. Also, we can, adding the propagation map, added the values in the, mapping the arrhythmia. And the propagation map, in fact, it tells us how the arrhythmia propagates in the chamber, where it's originated from, and where does it go to. Like in this illustration, you can see that it starts in here, same for the previous 3D mapping. So it starts from this spot and propagates distally from the site, and so we can know the mechanism of the arrhythmia. Also, the 3D mapping added a value of, evaluating the macular entry arrhythmia, like in the flutter case, when taking the, the geometry in relation to the activation. So it gives us the where should we go and, cut the circuit, so we can cut the tachycardia circuit. Also, the 3D mapping added a value in, anatomic mapping by illustrating, the structures. Like in this case here, it showed us, according to the electrical signals, recorded electrical signals, his bundle of his location, and also by tagging all the fascicular signals, and that tells us where are the fascicles located, imaginary localization. Without the 3D mapping, it might be very difficult to localize, the scar. Like in this case done by Dr. Ismail last Monday. And so we thought the case was, a flutter case, but after mapping the case, we saw that there is a huge scar in a young patient, 20 years old patient. So we saw, after taking the voltage map, where the voltage map is going to measure the, the live viable tissue from the dead tissue. So we found that there is a huge scar available, and there was like a source within it. There was a source of arrhythmia. So 3D mapping added a value by localizing the scar area and treating the the arrhythmia. Like in this case, also in the the V chamber ventricular, also adding the localizing the scars added a value of so we can know where to go and treat the arrhythmia. Also, in the case of afibrillation, localizing the pulmonary veins, so we can go and isolate them and treat the afibrillation, and also we can localize the CS, so we can go during if in case there is an arrhythmia needs to go inside the CS, so we can go inside it and ablate. So 3D mapping added a value also here, and it's added a great value in the treating the arrhythmia. So recently, not very recent probably, but as Dr. Ghalia already spoke about, the ICE, intracardiac echo, has been added to 3D mapping, so we can merge the the echo, the ICE, with the 3D mapping, and we can also build up the geometry according to the interested chamber. Like in this case, left atrium has been mapped. So also by knowing and tagging where ablation has been done, so we can know that if the procedure is accomplished or not. So we can know that if the the arrhythmia has been ablated successfully and the veins has been isolated. The 3D mapping by building the geometry and tagging the site of ablation also as like of a great value, but still without a clinical interpretation of the data, this might not be of a great benefit. So yes, true that the electroanatomic mapping systems are of great, greatly facilitate mapping efforts and reduces procedure time and fluoroscopic exposure. So no need to use the 3D the fluoroscopy so unnecessarily. So, but still, we need to carefully interpret all of this data and according to the clinical, interpretation and strict adherence to the electrophysiologic principles. So this was pretty much about my presentation. But still, by the end of the presentation, I would like to remind you that it's the end of the presentation. I might not cover all of the technologies in the field, but still the technology is going on and more advanced technology is going to be added soon, inshallah. Thank you for your attention, and this is briefly about my presentation. If you have any questions, I would love to hear from you guys.
Thank you very much, Mr. Saleh. Really, it's an interesting presentation. Always technology has interesting outcomes in all aspects. So we'd like to see if any questions with the control panel. I cannot see any question here, but maybe they have some questions. Any questions? Okay, Mr. Saleh. So one question, like if you want to map any abnormalities, like whatever, name it, in electrophysiology abnormality, how long it takes to diagnose or doctor can diagnose the problems? Like last slide, you said that you found patient with flutter, and you found that there's some dead tissue or whatever in the muscles. So how long it takes to figure out the
well, it needs some, there's no certain fixed times you can say, and it depends of the tools that you're using. Like if you are using a single, electrode catheter, that will make the procedure longer. But if you are using multi-electrode catheters, that will facilitate and accelerate mapping the geometry. Like using, for example, lasso catheter or pentaray catheter. These are catheters well known to the physicians, and also HD grade from St. Jude, which is of multi-electrodes that facilitates and accelerates the mapping of the chamber. So instead of taking 1 point, you will take multi, like 20 or more than 20 points at one click.
Well, thank you. Very interesting.
You're more than welcome.
Thank you very much. Mr. Ahmed, I don't know if Dr. Ismail is available.
Yes, he's on board.
All right. So,
Ismail, can you start sharing?
Maybe still he's trying to.
Dr. Ismail.
Yes, I can hear you.
Can you start sharing your screen?
Yeah. Just a second. You can
There
see
we
me.
go. Yes, I can see you. Okay.
Very good.
Welcome, Dr. Ismail. Our last but not the least presentation is going to be by Dr. Ismail Al-Abri. He's a senior consultant pediatric electrophysiologist at National Heart Center, Royal Hospital. So he's going to talk about congenital arrhythmias. Dr. Ismail, whenever you're ready, microphone with you.
Sorry, I think I have some technical issues.
Sharing the file, maybe you can.
I think all the technical issues in this webinar is related to Apple devices.
This is not Apple.
ما ركبت.
No, no, Apple will sue you.
Okay, now is it? Okay, can you see my presentation now?
No, I cannot see.
I think he left by mistake.
You know, Mr. Saleh, you did a very nice comment about how does the 3D map help you, and you know, it's the electrophysiology. It's about small pieces of information you add on one on top of the other from the beginning, from the ECG. The clinical characteristic of the patient, then you enter with a plan, and then the mapping, you discover something that was like the case that he presented, Saleh. It was unexpected to have this diseased left atrium. So what does it mean? It means that it's more suitable for flutters that are not related to common anatomical places. Or these pieces of information give you more and more visibility to what you are looking for and what you have to target. Sometimes you discover different things inside the procedure that may deviate the whole procedure to another thing.
Exactly, yeah. And the most interesting thing in the technology, the more you know, the more you don't know. So whatever, you know, sometimes we feel that you reach to your point, but by using the latest technology, you still need to search more and more. So this 3D is exhibiting a lot of problems which is unhidden.
And, yeah, but usually the good thing about electrophysiology, a good part of it is curative. Maybe it's the only branch of cardiovascular medicine that is curative, like accessory pathway, SBTs, PVCs. So you can know the result immediately, which is lucky in our specialty. You can know immediately the outcome. You can tell the patient what's the future plan. So it have all aspects and you know if you couldn't resolve the problem in the middle of the procedure, at the end of the procedure.
And I think you are lucky because you don't have the technology, because who is managing the technology also?
Yes, of course.
Yes.
We are always threatened by everything.
Yeah.
Even who's managing the technology,
Exactly.
if he's guiding correctly or not. Did he miss something in the middle that we didn't see? All these are different things that you have to monitor during a procedure.
Exactly.
If the patient is in emergency arrhythmia, you need to resolve immediately. You need to stabilize him. All these are different aspects in the same time that you have to command in a procedure.
Yes, you are right. I don't know. Dr. Ismail is trying to get his lecture on board, but
Dr. Ismail, we can see your device.
yeah, I think now we can see.
You can start the slideshow.
Now his slide here, but he's not here.
Let him unmute. He's mute. Dr. Ismail, you are mute.
No, I think
Okay.
no, he's not. Oh, yeah. Now we can hear you.
You can hear me and you can see my slide?
Yes, I can see your slides. Yes.
Okay, very good. And can you see me also or no?
I can hear you, but I cannot see you.
Okay. Now to
Maybe
fix this. Just a second, one more trial.
Yeah, now I can see you.
Start my video. Okay, what about now? But you cannot see my slide, can you? So you either see me or your slide? Yes.
I think I need to see your slide more.
I think it's better to keep to that.
Okay, fine.
Okay.
All right. Thank you very much. So thank you for this invitation. So can I start now?
Yes, you can start. Go ahead.
Okay. Thank you, Saleh, and thank you the rest of the Cath Lab team for this invitation. And you're always very active in arrangement. So today I'll try to talk about mostly, since we are in a Cath Lab meeting or in a more technical meeting, I'm going to talk about more of technical issues in what we do in abnormal hearts. And when abnormal hearts I mean the patients with the anomalous or congenital heart diseases. So there are very important consideration we have to take in our mind when we try to do the procedures for those patients. And so first of all, the access might be different from the patients with the normal heart. You might not have femoral vein access, or sometimes the left vein or right vein is occluded because of previous intervention, and also the an abnormal anatomy. Another variable is very important is the age of the patient, as we know that many of our congenital heart disease patients are young population. So some of them, they are infant, and some others are also living to the elderly life. Okay, so this is also an important consideration we take during the procedures. Scars and incisions in the past in the heart also very important to know and to understand, and where are they located. And of course, the anatomy itself, whether it is a no abnormal anatomy of the heart, whether it is single ventricle or two ventricles. And the other issue is sometimes you have a normal anatomy of the heart with an abnormal conduction pathways, or location of the AV node, for example, or coronary or other conduction tissues. So it's very important to have to be very well prepared for those patients, and you don't wait for surprises to come during your procedure. And so the pre-procedure preparation You have to, know the history very well, know the what kind of patients you have, what type of interventions he had in the past, what type of surgeries, and you have to prepare your list very well. And if you have, for example, a very complex case, then what you need to do is you need to maybe book only one case for that day. If it is patients with multiple interventions in the past, you might end up doing it for 6 or 8 hours for one procedure only. So you cannot, put a congenital ablation of congenital heart disease with, in your usual list. And that's why we make it usually on Thursday, and we try to make only 1 or 2 patients. Okay, you have to review your anatomy very well. How many, what type of anatomy, what type of surgery this patient done, and I will show you some examples. And as I said, review of previous interventions. And then during consent also, you have to be, you probably have to take the consent differently. One thing you have to mention to the patients during the consent is the timing of the procedures. That is most likely going to take long time. The other things, it's in case of congenital heart disease, and we know from literature that the recurrence rate is much more higher than normal heart anatomy. So you have really to tell the patient during the consent might not be the end, might not be the last procedure you are doing. Okay, so the other thing is item preparation. Very, very important. What type of anesthesia you need? You need only local or general. Most of the time we go for general anesthesia for those patients because it is usually a prolonged procedure, and some patients have, of course, abnormal anatomy, abnormal cardiac function. So many of the time we need this one, anesthesia. We have had a very nice talk from Saleh, my previous presenter, about 3D mapping. And I always insist on 3D mapping for the patients with congenital heart disease, because you really need to understand where are the scars, where are the incisions, where is the level of the valves exactly, and what are you dealing with, the veins, the connection. So it is very important. The access again is very important. Where are you going to have your access, right or left femoral vein? You need an arterial access. It depends on the anatomy that you have. We'll give example later on. Again, what type of catheters we are going to use? Are we using the normal catheters that we use for the other patients? It's usually the same catheters, of course, that we use, but sometimes the patient does not have a coronary sinus. Okay, and so you don't need a coronary sinus catheter. Sometimes the patient has only one single ventricle, so you might only in one ventricular. You only need one catheter that can be moved from one area to another. Wires, sometimes we need wires to to guide us to go to special areas, and many of the time we need also wires for the puncture itself. Needles that we use for punctures in younger patients are different from the older ones, of course. So those are very important consideration. Another very, very important thing is the transeptal puncture. Transeptal puncture in patients with congenital heart disease, many of the time it's different. Sometimes the patient, for example, have had an ASD closure by either device or by a patch. So the perforation of that septum is not as easy as if you are perforating normal septum. So you might require to use cautery to do your transeptal puncture, and also localization of the area of the puncture require many of the time an ultrasound assistance, either by ice or by transesophageal echo. So what are the lesions that we are dealing with? Of course, we have as simple as atrial septal defects that can have arrhythmias, and these are the most common ones. Epstein anomaly, many of them has 40 to 80% of them will be having an SVT. Single ventricle patients, especially those ones who went for Fontan, the reported number is usually 40% of them. Now it's even more, up to 60% of them will have an arrhythmias that need to be treated. Transposition of great arteries is a very common, also an important substrate of patients that we have. Of course, tetralogy and tricuspid valve operations in the past also have a substantial number of patients who will go to arrhythmias. And of course, the ventricular septal defects are more prone for arrhythmias than others. So as I said, understanding anatomy for those patients is very, very important. So what type of anatomy this patient have, whether it was a single ventricle or two ventricles, and what type of intervention was, or what kind of incision was made in the past for the patient. Was it only, single incision or multiple incisions? And sometimes you have to go and read the surgical note clearly so that you understand the anatomy very well. Next is also, after you understand your anatomy, you have to go also and understand what type of anatomical diversions has been done. So some patients will have had, like, for example, Mostard or Senning procedures. So everything will be disturbed, and your catheter will go into a different. Next, for example, in the patients for tetralogy of Fallot, we know that how they prepare it, or sorry, how they repair it. Just for a refreshment for people, tetralogy of Fallot means that there is a large ventricular septal defect overriding of aorta, and there is also of course a narrowing of the right ventricular tract, and there is a hypertrophy of the right ventricle. So the way it is repaired usually by transannular patch, and this is usually done by stitching, stitching around this area. They will stitch the they will do a transannular patch here to open the RPOT, and then they're going to stitch it. So you might have a rotating tachycardia around this patch, between the patch and the tricuspid valve. Other ones, for example, an ASD, when they close it, they will just do a patch here in the ASD area, and there might be a rotational tachycardia around this patch. And another, of course, incision when they made the atriotomy incisions. That atriotomy incision also might be a substrate for a cath. Sorry, for tachycardia in the future. Fontan patients, as I said, around 50% of them now will get atrial tachycardias in the future. So we have to know where are the scars that they have, where are the, what is the rotation of the tachycardia. Of course, the success of this procedure will be impossible without 3D mapping. I'll just share you at the end one case that we have done recently that highlights the importance of understanding the anatomy of the patients. This is a 40-year-old who had surgery in the past when he was 1 year old only. And then after that, he never followed up. He came with palpitation to the emergency room. And as you can see that this patient has what looks like a wide AQRS tachycardia. So we try to understand the anatomy of this tachycardia. Sorry, the physiology of this tachycardia and how was it going, and whether it is sinus or not sinus. Of course, as you can see, the ventricular rate is around 140, 130. Okay, and it is quite regular, and we cannot appreciate sometimes where are the P waves. Okay, but as you can see here, these are probably the P waves that the patient are hiding between the QRSs. So we came to understand that this patient is actually having this one a flutter. So now we went through his, of course, he didn't have any surgical note in the past, and we had to communicate with the, surgery was done abroad. We had to search for his surgical note, and finally we had to do an MRI, cardiac MRI, to understand his anatomy. So eventually we knew that this patient had what we call an interrupted IVC, okay, with the hemiazygous continuation. He had a single ventricle because of pulmonary atresia also. So he have only almost one atrium and one ventricle, as you can see here. And so the blood was diverted, the whole blood was diverted to the lungs by what we call a Kawashima procedure. So now we know that this patient has an atrial flutter or atrial tachycardia, but we don't understand how was it progressing, or so how was it going. So of course we had to use 3D anatomy, 3D mapping to understand it. And we used the cardiac MRI images to help us and understand where could be the tachycardia coming from and what are we going to ablate. So eventually we did a 3D mapping for this patient, and we understand that the tachycardia was rotating something like this around the AV valve, and the isthmus was the hepatic veins. So the isthmus was between the hepatic veins and the tricuspid valve. But the problem was this patient did not have an inferior vena cava that is going to the heart, and a superior vena cava also going to the lungs. So all the venous drainage now is going to the lung except hepatic. So we have to reach that area. What we normally do, we go from IVC easily to ablate flutter to go to this area, but this patient did not have an IVC. So we came up with another plan to go through the retrograde aorta, and then went to that to the single ventricle, and we went back into the atrium to the hepatic vein. And from the hepatic vein, we could throw the catheter and made a line of ablation, and that interrupted the tachycardia to sinus rhythm, as you can see. So sometimes it's not easy to understand the anatomy or the how the tachycardia is rotating, and how this congenital anatomy is, how the atrial tachycardia or tachycardia is rotating around the heart. But you have always to believe in yourself, and then eventually, hopefully, you will get it. So that's the end of my presentation, and sorry for the technical issues that today I experienced, and I hope that you enjoyed the lecture.
Thank you very
Hello?
much, Dr. Ismail. Hello?
Yeah, I can hear you.
Yeah, thank you very much for the interesting lecture, and you made it in good time, in fact. So we just need to see whether there is any questions, or I don't see any questions here.
Maybe people have left already. Am I the last presenter?
Yeah, you are the last presenter, yes.
Yeah, maybe all people have left already.
Because even the previous presentations, we didn't get any questions. I don't know, maybe because they don't have questions, or maybe they face some difficulties in posting the question, maybe. Anything, Ahmed? Any question? Any from your side? Hello?
Actually, no question, Sarah.
No questions, huh?
No question.
All right. So shall we close the sessions? Well,
Dr. Ismail, I have a question here, Saleh.
Okay.
Dr. Ismail, did you notice from your experience and doing all this kind of pediatric related congenital arrhythmias could be that there is certain arrhythmia related to a certain structurally or anatomical congenital disease?
Yes, of course, from our experience and also from the international data, that we know that there are certain congenital heart disease are prone for specific arrhythmia. Like we know that Epstein, at least 30% of them will have an accessory pathway. Okay, and then also we have started doing EP for all Epstein patients who are going for surgery before surgery. Even though there is no excitation, we'll still send them for study to make sure that they are not hiding any accessory pathway that makes their post-operative course is difficult. The other things, of course, all Fontan patients will definitely have, or many of the patients with Fontan will have, arrhythmias in the future, like the last case that I showed. And the other things that we have noticed, and it's also noticed somewhere else, patients who have tachycardias and atrial fibrillations. Okay, these are of course tachyarrhythmias. There are other congenital heart disease that are more prone for bradyarrhythmias and for heart block, like for example, congenitally corrected TGA. So each substrate or congenital heart disease has its own substrates and different type of arrhythmias that they present with differently from the normal population.
Okay.
And regarding the structures, what about these like more, histological, according to the cells? Like, for example, somebody's lacking, mitochondria is not there, and so they are having certain arrhythmias. Do you do like, genetic disease, investigations before you, start, decide to treat the arrhythmia, or what do you do?
For patients, there are, I don't know whether you are alluding to patients with storage diseases, like mitochondrial storage diseases. Those patients might have some abnormalities in their myocardium that might also start their arrhythmias. The majority of those are bradyarrhythmias. Okay, so they will get most of the time heart block rather than supraventricular tachycardia. We have only one patient recently admitted, I think 2 weeks ago, a small baby with metabolic disorder and an accessory pathway. This is the first time we have noticed this. But most of the time, the metabolic team and genetic team will take care of the treatment of the mitochondrial disease. And in case that the patient is well to be treated by by us, also they will send him to us. But many of those patients are very sick and they're very difficult to control, their metabolic issues. But in case, of course, they have disturbing arrhythmias, we will be able to treat them.
Dr. Ismail, Dr. Ismail, I have a question. Have you ever seen a patient with any kind of arrhythmias and needed mechanical circulatory support, like ECMO or any mechanical support, bridge to therapy?
So there are patients with what we call the patients who have incessant arrhythmias, and we have had a patient actually 2 weeks ago who was an infant with I think second or third day of life, who have an incessant SVT that could not be terminated by any medication. And the patient is usually, that patient was having already poor function. Probably he have had intra-uterine arrhythmias. That patient, when I saw him, he was in poor status, poor perfusion, metabolic acidosis. So the only thing that could have controlled him, either we control his arrhythmia, or he dies, or he goes for ECMO until his heart, recover from the incessant arrhythmia itself. We were lucky that we gave him flecainide, and then we could terminate his arrhythmia after like 20 or 30 minutes.
Okay.
But they were trying in the other hospital for a long time to control it, and the patient was in poor status, in poor perfusion. I have seen in another hospital twice a patient with incessant arrhythmias. They gave them beta blocker, and after the beta blocker, they crash. And one time we gave them amiodarone. After the amiodarone, they crash. And of course, after they crash, the only thing that we can save them is by ECMO. Okay, we send them for ECMO to rest the heart a little bit until the arrhythmia is under control. The other important also one is incessant VT. Okay, that also incessant VT can also be a candidate for ECMO until you are able to control the arrhythmia. Very good question, sir.
All right, thank you. Any other questions from audience? Well, thank you, Dr. Ismail, for coming and sharing with us this presentation. Thank you very much.
You're welcome. Thank you very much.
Thank you.